Hello everyone, I am Flavio Ribichini and it's 3 o'clock and it's time for a new PCR webinar on DCB. Today, live from Paris, we will talk about what is the optimal result after DCB. If you are attending this meeting and you are behind the screen, it's because you want to learn how to prepare the de novo lesions. This is on de novo lesions for drug-coating balloon-based PCI. You want to learn what is the acceptable or the unacceptable final result of a drug-coating balloon-based PCI. But above all, you want to see the long-term results of this specific treatment because we want to tell you that the optimal result is what you get at the long term, which most of the times is more rewarding than what you get immediately after. To do this work today, for me, it's a pleasure to share these next 60 minutes with colleagues and friends, Professor Fernando Alfonso from el Hospital La Princesa, the University Autónoma de Madrid, Professor Azfar Zaman from the Newcastle upon Tyne Hospitals in the UK, and remotely joined by Professor Frankie Tam from the Queen Mary's Hospital in Hong Kong. Thank you, Frankie, for joining us despite the late timing in your place. So without further delay, we will start providing you the evidence behind this treatment. And for that, I will ask one of the world experts, because Fernando has been doing trials since at least 20 years in this aspect. So Fernando, please go ahead.
So thank you very much, Flavio. Thank you for the invitation. It's a pleasure to be here with this group of experts. And I will try to summarize the best I can the information regarding the use of drug-coating balloons in patients with de novo coronary lesions. But first of all, please remember that there is a very clear indication for the use of drug-coating balloons, and this is in patients with in-stent restenosis. So this is supported by the European guidelines with a 1A indication. Going to the de novo coronary space, I think it's important to remember this very early study by Hassan Latif and Antonio Colombo, where in a randomized design, they compare Plaquitaxel drug-coating balloons versus Plaquitaxel eluting stents at the time in patients with small vessels. The primary endpoint was lay lumen loss, and obviously the more you gain, the more you lose, but in this study the primary endpoint was met and was better with drug-coating balloon as compared with Plaquitaxel eluting stent. Clinically, at the beginning, the first year, the results were similar with the two strategies, but you may see that in this second publication, with a 3-year follow-up, despite a non-significantly different rate in TVR and TLR, eventually the clinical outcome of the combined clinical endpoint was better in the drug-coating balloon arm. So this was a very strong signal. After that, Basket Small came, and this is a much larger study. In fact, this is a power for clinical endpoints, which is a combine of cardiac death, MI, and TVR. And in the initial study and also the follow-up that was published 3 years later in Lancet, you may see how for patients with small vessels, the use of Plaquitaxel coating balloon was similar to the use of mainly first-generation drug-eluting stent at the time. So this is strong data supporting the value of drug-coating balloon in de novo. This is a study by Bernardo Cortese that we had the opportunity to participate, and this is different, it's complementing the prior study because this study is looking for angiographic outcome. In this study, a Plaquitaxel coating balloon was compared with a standard everolimus eluting stent in patients with small vessels, and again, the late lumen loss was superior for drug-coating balloon patients treated with drug-coating balloons. Again, initially, the clinical outcomes were similar in the first year, and the remaining surrogate angiographic parameters, as minimal lumen diameter, percent diameter stenosis, was similar in the two arms. Interestingly enough, At the 3 years follow-up, you may see that all events are numerically higher in the everolimus-elutnisten arm, and eventually the main MACE combined endpoint was in favor of drug-coating balloon in this study. We performed also a meta-analysis in patients with de novo lesions with Islam El-Hendi, and we include 14 randomized clinical trials with 2,500 patients that were followed by a mean of 12 months, as you may see here. In this study, there was no difference in TLR, that was the primary endpoint of the study, with drug-coating balloons as compared with the alternative strategies used in this study. And there was also no difference regarding the indication. Small vessels, myocardial infarction, bifurcation, high bleeding risk, all the endpoints were consistent with the main outcome measure. In addition, when we only compare drug-coating balloons with drug-eluting stents, again, there was no difference. So this is just the summary of the 14 randomized clinical trials. You see the primary endpoint, TLR, the summary is no difference. And there was a strong signal, in fact this was statistically significant, that the use of drug-coating balloons was able to reduce, during follow-up, the occurrence of myocardial infarction. So this is very interesting information. Now, we got also information from different drugs used in drug-coating balloons. And this is probably the largest registry, again by Bernardo Cortese, the Eastbourne registry, including, I will say, real-world patients, some of them in stent restenosis, no angiographic follow-up, a very close and well-organized clinical follow-up. And you may see here how the events, in particular target lesion revascularization, was very late. And you may see in the right-hand side how when we divided the population into patients treated with de novo or in stent restenosis, the results were better in de novo patients than in patients with stent restenosis, which is supporting findings in prior studies. Now, this is a very interesting randomized clinical trial that is being published very recently, is the TRANSFORM-1. Here, in patients with small vessels, de novo lesions in small vessels, two different drug-coating balloons were compared. The classical paclitaxel-coated balloon versus a novel sirolimus-coated balloon. And in this study, the non-inferiority primary endpoint was not met because late lumen loss was larger with the sirolimus-coated balloon as compared with nearly zero late lumen loss as an average in the paclitaxel-eluting balloon arm. And if we just go to the details in more, the results in more details, you can see on your left how the angiographic net gain, that was the primary endpoint of the study, was better for the paclitaxel-eluting balloon arm. And on your right, you can see how when we analyzed the late lumen loss, there was a difference, and there was negative late lumen loss. This is late lumen enlargement, more frequently seen, more than half of the patients, in the paclitaxel-eluting balloon arm as compared with the sirolimus. So this is something that we will discuss later on. Studies going on, major studies. One is this, the SOLUTION study, which is going to be finished very soon. In this study, two strategies are compared as a strategy. First, the conventional, the implantation of a last generation everolimus-eluting stent, as compared with a strategy where drug-coating balloons are used, but there is no problem if during predilation the patient got a dissection and eventually requires a stent. So this is the strategy. So in the drug-eluting balloon strategy, if no good results are obtained during predilation, there is no problem, patients can be treated with a stent. And the other major ongoing randomized trial is this study, TRANSFORM-2, by Bernardo Cortese. The primary endpoint is target lesion failure at 1 year, and 1,300 patients will be included to demonstrate non-inferiority of this sirolimus-coated balloon as compared with the standard of care, which is in this study considered everolimus-eluting stent. So basically, to conclude this first part of the presentation, not all drugs are created equal. Not all drug-coating balloons are created equal. Drug-coating balloons are here to stay for in-stent restenosis. There is no question on that. But there is also major potential for the use of drug-coating balloons in de novo lesions. Regarding the novel Limus drug-coating balloons, well, further evidence is required, but I think this is a very promising landscape.
Okay. Thank you, Fernando, for this nice landscape for starting. Now I'd like to go to our colleague in Hong Kong, who is very expert and has a lot of experience in using. And so, Frankie, we'd like to ask you if, on your experience, your opinion, if there are lesions that could be excluded for this treatment, or there are better indications or worse indications?
Yes, thank you. That's a very practical question. Yeah. So basically, to myself, using DCB for de novo lesion is a philosophical question. So I think before the lesion preparation, to me, there's no absolute indication or contraindication for use of DCB. Can I have the slide, please? Yes. So, but of course, there are some preferred or less preferred lesion for use of DCB for de novo lesion. For example, if there's a small vessel, tortuous, diffuse disease with no good landing zone, probably DCB is preferred. Of course, for soft plaque, fibrous plaque, because it's more responsive to predilatation, again, DCB is preferred. And also for bifurcation side branch, the use of DCB may probably reduce the chance of using complex treatment strategy. Again, DCB is also a very good alternative. On the other hand, there are some lesions that DCB may not or may be less preferred. For example, large vessel, left main, proximal vessel, or calcified plaque, or some people, for example, for myocardial infarction, STEMI or non-STEMI, they may not dare to use DCB. But of course, these are all relative. So somehow we will illustrate this in some case later on. But after lesion preparation, in contrast, there are some lesions that we should not use DCB. For example, there are some suboptimal results of the lesion preparation. For example, more than 30% lumen stenosis after predilatation, significant dissection, type C or above, or even reduced TB flow. Of course, some people will use intravascular imaging or even physiology to guide whether a DCB can be used after lesion preparation. This will be elaborated more by the speakers in this talk later on.
Thank you. Thank you very much, Frankie. Well, at this point, we have already provided you quite a good baseline to start the discussion. So from now on, I want to remind you that these webinars, PCR webinars, in this case supported by a grant from Medtronic, is made for you, but it's also made by you. So from now on, we will discuss cases, we will comment on opinions, and we expect you to write me here in this iPad your points, so you can participate directly. And I have to make a compliment to our most faithful colleague, Nabil Chowdhury from Kenya, who is a frequent flyer in these sessions and is ready to go for the first question. So from now on, we will show you the cases on the basis of which we will discuss. Frankie, you have just said that there are no good or bad indications to use DCB, but you would rather consider it after an adequate lesion preparation. So what we have prepared for you now, it's a case of a patient I did a year ago. It's a young male with normal LV function, stable angina, and a little improvement after medical therapy that comes to Verona with this coronary angiogram. It's a young patient, has already a pacemaker implanted, and you see he has a total occlusion of the LAD. Apart from that, there is another lesion on the oblique marginal that looks very like a type A. So in our clinical practice and working on the basis of our knowledge, the first lesion is a CTO, and it's likely the most adapted to use a stent, while the other one is a type A, so by definition it would be a very good one to go without a stent. But as Frankie has just told, I mean, the decision should be taken at the end of the lesion preparation. So I started opening the vessel and having an idea of the quality of the vessel with a semi-compliant 220 balloon after crossing with a dedicated wire. And what we see, it's a diffuse disease and a rather small vessel. Further lesion preparation with a 2.5 30 millimeter balloon shows a rather nice angiographic result after preparation also of the distal part. And so now it comes the first question for all of you at home or at your office. Do you really need a stent at that point? I mean, can you please play again the image so that our colleagues can appreciate how it looks after only balloon? And so the question for you is, would you still implant a stent after this preparation, or do you think that we can proceed with DCB? So while our colleagues prepare their questions and sent to my iPad, very briefly, as far, would you leave this lesion like it is with only balloon, or would you put a stent?
No, I think you have an excellent result with angiographic restenosis in the LAD of less than 30%. So if you look at all of the published data, TIMI-3 flow, less than 30, leave it to remodel.
Okay. Fernando, do you agree?
Well, I think it's a small vessel with diffuse disease, as you mentioned, and there is a major branch taken off from there. So perhaps stents are not very appealing, but to tell you the truth, in my cath lab in Madrid, CTOs are still treated with a stent. So in my practice, I will use a stent, even though the possibilities of using drug-coated balloons are there.
This is why I wanted to bring this case to you, because of course it's provocative. So the case was treated with two long drug-coating balloons, and this is the final result with normal TIMI-3, very small dissection and non-compromise of the side branches. So, but we still have to deal with the oblique marginal lesion. And on my mind, that was the good lesion for DCB. So I started with the lesion preparation. I started with the semi-compliant 3O balloon, but you see that after the dilatation, the recoil of the lesion is still very significant. So my next step was using a non-compliant balloon, going higher in atmospheres. And again, what you see is that the lesion still stays there. So the second question to you, the experts, but also to our colleagues, is whether you would consider this lesion still as a good lesion for DCB, or if you think we would rather go with more lesion preparation or directly with a stent.
So on the same basis, you could use a cutting balloon, you could use a scoring balloon, but you've got quite acute recoil here with angiographic residual stenosis of over 30%. So this is a good case for just leaving with a drug-eluting stent. And I said that should not be seen as a failure. It's there as a bailout.
Okay. Fernando, very briefly.
Well, yeah, basically the same. I mean, these focal lesions, perhaps you need to make sure that there is no watermelon seeding or any kind of missing the lesion. Obviously, that was not the case because you did it. And you can try a cutting or a scoring balloon, but with this recoil, I mean, going for a stent is straightforward.
Okay. This is exactly what I thought. I didn't want to lose more time trying with other devices. It is not a calcified lesion. It looks fibrotic, probably. So I went with a stent and a post-dilatation, and the result, as you can see immediately, is very good. So we have the first answers for the first question. I can tell you that 90% of our colleagues would agree with Fernando that in the CTO would go with a stent rather than DCB. But what we want to show you is the 12-month follow-up of this patient. You can see on the right side of the screen how the LAD looks 12 months later, much bigger, no dissections, absolutely no restenosis and perfect flow. So despite what we think, these DCB indications was very good. And as expected, on the circumflex, the stent did its job. Of course, we have caged the vessel in a young patient, but we cannot say this is not a good result. So this is the case summary, the baseline, the immediately after result, and the long term. And I am getting now the answers of the second one. And again, as expected, most of our colleagues, 80%, would have gone with a stent on the marginal, and nearly only 10% who had tried more lesion preparation and DCB. Okay, one of the questions coming from a colleague, Cesar Vigo from Argentina, is there any concern about late thrombosis after DCB? Who will address this question? In the meantime, I will run the OCT to show you the excellent vessel reconstruction of this LAD after DCB at 1 year. Stent thrombosis and DCB.
So there is no evidence at all that when you use DCB, once the patient is outside of that 24-hour window, we have very powerful antithrombotic therapy these days, that there is any evidence of late stent thrombosis. And that's one of the huge advantages of using DCB.
Fernando, something to add?
I mean, there is major data accumulating saying that if you pass the initial phase where there is a minor risk if you don't follow the strategies by the international group of DCB, I mean, the possibility of having a vessel thrombosis at the area you treat with a drug-coating balloon are very, very rare. I mean, virtually not described.
Yeah, and this has been shown in the trials. I mean, trials comparing DCB and stents actually show more acute and late thrombosis after stenting rather than DCB. So, good. At this point, you have all seen this fantastic reconstruction of the LAD without stents, without restenosis. And then I will move again to Frankie to ask him some tips and tricks on how to assess the final result of the balloon-based PCI. Frankie, are you still there?
Yes. So now next comes a very important topic of the lesion preparation for a good lesion preparation for a DCB.
You first mentioned that it's important to get an angiographic result with the residual stenosis lower than 30%. Yeah?
Yes.
Which is your opinion on the importance of the dissections?
Yeah. And of course, besides the angiographic stenosis less than 30%, second thing is that we should not have a type C or above the section. And thirdly, more importantly, is to have the TIMI-free flow. And practically what we have to do for lesion preparation is, first, usually we start with a semi-compliant balloon, a smaller balloon. And then we will try to use a bigger balloon. Usually we size the balloon with the vessels either to 0.9 to 1 to 1. So almost a 1-1 sizing to make sure that we have a very good lesion preparation.
Okay, so Frankie, we are insisting more and more that in complex and calcified lesions, we should not try direct stenting. Do you think that this is a concept that we can translate also to this technology, avoiding direct DCB treatment?
Yes, so for the stenting, sometimes we will do direct stenting. But for DCB, I would say there's no such thing of direct DCB. So for DCB, it's just a drug delivery. We have to make sure that we have a very good lesion preparation with less than 30% residual stenosis, with minimal less dissection, such that we can put a DCB. So there's nothing that have a direct DCB. We must have to prepare the lesion well before we do the drug delivery.
Thank you very much. Asfar, there are other ways of assessing the immediate results of a balloon, not only angiography, but we don't know how much importance we give to physiology or imaging. Can you tell us?
Yes, of course. Thanks, Flavio. So this is what I'm going to tell you in my lecture about the role not just of angiography, where we have the greatest experience, but also of coronary physiology and intravascular imaging. The data is limited, but let me tell you. So first and foremost, if you're going to be an advocate for drug-coated balloons, you have to understand the Glagov phenomenon. And Glagov demonstrated that vessel wall, through flow mediation, leads to outward remodeling, and we saw that in Flavio's fantastic case of that CTO, where a year later the vessel had grown, and this is what Glagov described, where you have preserved lumen diameter with normal TIMI-3 blood flow. And he described that if the stenosis from a developing plaque is less than 40%, the lumen diameter is preserved with an increase in vessel wall mass and the external radius. So the vessel grows, and this is what we've seen. So you need to understand Glagov to feel comfortable with using DCBs. Now, Frankie touched on dissections. This is an old definition of dissections going way back into the 90s when balloon angioplasty was the standard therapy, and the dissection types were described from A to F. So you can see that in the diagonal, you have a dissection very clearly visible, but TIMI-3 flow, this vessel was left unstented. In the LAD, you also see dissection with some dye holdup, and you can argue that this flow is not exactly TIMI3. You can see the diagonal fills, and this lesion was stented at the time with excellent final angiographic result. So the most clinical and published evidence exists for angiographic assessment, where you have a non-flow limiting dissection with TIMI3 flow, residual stenosis of less than equal to 30%, and these lesions are safe to leave behind with low risk of target lesion failure. What about the role of coronary physiology? Well, this is a large Korean study, is about the only data that exists where large numbers of patients underwent coronary physiology after balloon angioplasty prior to DCB. If you look at panel A in the top left, the y-axis is a cutoff of 0.75 for invasive coronary physiology. The x-axis is a cutoff of 30% for coronary angiogram assessment. You can see that to the top right is what we call the mismatch, where you have angiographic restenosis of greater than 30%, but an FFR of 0.75. These lesions are safe to leave behind. In the bottom left panel, in the yellow, you have what's called the reverse mismatch, where you have angiographic restenosis of less than 30, but an FFR of below 0.75. These are the lesions that we worry about because it doesn't allow us to leave them behind. Now, if I draw your attention to panel B, which is the left anterior descending artery, you can see that the reverse mismatch only is seen in the LAD lesions, whereas in the circumflex in panel C and in the panel D right coronary arteries, there is no reverse mismatch. So you can use coronary physiology to make the assessment. Now, is there a relation between the dissection type and invasive coronary physiology? Well, if you look at the first panel A, there seems to be no clear relationship, so that type D dissections, 50% have FFR that is in the normal range above 0.75. And you can see this in the colored panel to the right. So there doesn't appear to be a clear relation between dissection type and invasive coronary physiology. And this is the suggested algorithm if you insist on using invasive coronary physiology or any coronary physiology. So lesion preparation, if you have decreased flow with less than TIMI3 flow, drug-eluting stent. If you have normal flow and you choose to do FFR, then that is your algorithm. If the FFR is greater than or equal to 0.75 or IFR 0.86, you continue with DCB therapy or use a drug-eluting stent if it's not. So in summary, in coronary physiology, we do see a mismatch, but this is seen in this study at least only in the left anterior descending artery. So if you're going to prepare the circumflex and right, you can be comfortable using angiographic assessment of the lesion. It suggests that the drug-coated balloon can be delivered safely and effectively after balloon angioplasty, provided there is TIMI flow grade 3, and this is important, with an FFR value of greater than or equal to 0.75. And importantly, the dissection type after balloon angioplasty does not correlate with residual FFR. So, for coronary physiology, FFR-guided drug-coated balloon treatment may reduce the number of unnecessary stent implantations only in the mismatched population, which is largely seen in the left anterior descending artery.
Okay, so before we move to the intravascular imaging, do you use physiology in your practice to guide your decision?
No, I've not used it. No. So angiographic assessment for me is what
it seems to be more reliable in non-LAD lesions.
Correct.
So we can leave worse results on the right and the circ, and we will be more demanding with a good result in the LAD.
I agree, but I think with the increase of non-invasive coronary physiology, Flavio, I do think that we will see more and more of this use, particularly in light of that data, for DCB use.
Yeah. Of course, Fernando, do you use it? I mean, is it putting a physiologic wire, something, comfortable? We don't like to put a second wire.
In case of doubt, it's a possibility. Actually, we don't use it in everyday clinical practice when we use drug-coating balloons in de novo lesions. But there is data coming, for instance, from Antonio Colombo that FFR, but also the gradient, just the numerical gradient is of value in these cases. And there are other groups that suggest that there is a delta in FFR. So if the saying that we can predict a problem when the dissection is changing, the angiographic dissection. If there is a change in the FFR, you wait a little bit in the cath lab. Well, this is also another strategy to make sure that you are leaving a good result.
This has to do because we are receiving a lot of questions regarding the use of physiology, whether we can trust non-wire-based, but rather angio-based physiology. You said that far, there is a lot of room for that.
I think our experience of non-invasive FFR physiology will continue to increase over the time. And certainly if you look at the data that exists now, it shows good correlation with invasive FFR.
And then the point that not necessarily physiology corresponds to the angiographic images. You showed that.
So not to the dissection, and that's important to note. So to your question, if you are not using a physiology wire to begin with, my personal feeling is that to put a second wire when you have a dissection would be risky. So if you have a physiology invasive wire already there to begin with, fine. But why would you do that?
No.
So I think that study would relate to non-invasive physiology much more so than invasive physiology.
Good, because there are many softwares being developed, we will not make names, but it's getting more and more daily practice.
Correct.
What about intravascular imaging? Does it help?
Thank you. So once again, data is limited. So this is a study of 247 patients who underwent PCI with DCB alone. And the IVUS analysis revealed that if you had a residual plaque area in this study of greater than 58.5%, so let's say over 60%, it was associated with target lesion failure. And this figure of 60% fits in with older data from directional coronary atherectomy, ORS and Abacus, which also supported a residual plaque area of less than 60%. So lesion preparation, if you're going to use IVUS to guide you, you should achieve a plaque area after balloon angioplasty of less than 60% in order to achieve the best outcomes. Now, the only study that I could find is this observational study from China, where they looked at 1,157 patients who were treated with drug-coated balloon with a median follow-up of 32 months. It was a retrospective observational study, and only 7.8%, 90 patients, had undergone intracoronary imaging guidance. And essentially, the take-home message was that there was no statistically significant difference in target lesion failure, cardiac death, or target vessel MI rates when IVUS was used in comparison to angiographic analysis. There is, however, a consensus statement from the Japanese Society that puts intravascular imaging at the core of assessing after predilation, and they state that if there is an absence of major dissection, type C to F in angiography, or medial involvement or significant hematoma detected on imaging, then you may put a stent in. And once again, I make the point, putting a stent in is not failure. You need to understand when it is safe to put a drug-eluting stent and when it is safe to leave DCB alone. So for intravascular imaging, there is limited data. I would think that as now with stents, it's useful in calcified lesions to make sure that you've cracked the lesion so that it can remodel favorably, but there is no consensus overall on how to use IVUS or OCT to guide when using a DCB strategy. So in summary, please remember, as Frankie has said, drug-coated balloons are drug delivery only. You really do need to prepare the lesion, use angiographic or IVUS, physiology, whatever you feel comfortable with, but the lesion must be appropriately prepared beforehand. Current recommendation is that if you have residual angiographic stenosis of less than 30% with TIMI-3 flow or a plaque area on IVUS of less than 60%, these are the cases that will do best with a drug-coated balloon strategy. There is limited evidence for intravascular imaging. FFR can be a useful adjunct. And remember, and this is very, very important, dissections are normal. Good balloon angioplasty will always leave a dissection, and it is to be expected after successful balloon angioplasty. And it is only the flow-limiting dissections, TIMI less than 3, that you should consider for stent placement. Thank you.
Thank you. Thank you very much, Asfar. In summary, we have to rely more on angiography and clinic rather than. Now we will make you 2 questions to verify whether you have been paying attention. The first question is, which is the recommended balloon to vessel ratio? 0.8, 0.75, 0.9, or 1? And the second question, because we put the two questions, give you time to reflect, give me an answer, and in the meantime we move to the next case. Which kind of dissections after balloon can be safely left with DCB? If there is a TIMI flow 2, if there is a TIMI flow 3, you can leave it with a TIMI flow 1, or any kind of dissection would be treated with a stent. While you think about and you let us know what you have learned from this first part, we move to another provocative case. We said there are no exclusion criteria, but of course, vessel preparation is key. Again, this is a case done last year in a patient with 76 years old with stable angina and atrial fibrillation with oral anticoagulation. You can see that the LAD is diffusely diseased. It's a very calcified lesion in the proximal and mid segment. So we start with lesion preparation, a non-compliant balloon, 2.5, which shows both a good opening of the balloon and an effective dilatation of the lesions. What's next? Well, being a very calcified lesion, we decided to go with IVL. Actually, the patient is enrolled in a study of IVL and DCB, which hopefully we will finalize this year. So what you see after a non-compliant 3.0 balloon, it's again a good expansion. This is only angio-guided. But after this image, the final test, it's a semi-compliant long balloon 330 that shows indeed a very nice expansion. And the angiographic result of this lesion preparation looks quite well. So, Frankie, the question goes to you and your experience. This is a calcified vessel, 3.0, long lesion, and this is the angiographic result. Would you still plan to put a stent there, or you think we can go with DCB?
So this is a very nice case, which, well, as you mentioned, a bit provocative. So this is a very long diffuse calcified lesion, but somehow after your balloon preparation and the IVL, it seems that the TIMI flow is very nice. TIMI free flow, just very small dissection. We just type A dissection with very nice opening of the vessels. As Dr. Zam has mentioned, a good POBA, a good lesion preparation always gives some dissection. So in this case, I'm very comfortable to go with a DCB. But just reminder for the audience, even we do a DCB here doesn't mean we cannot put in a stent. So after the DCB, if there's always some problem, we can always do a bailout stenting. So this is the key to the use of DCB.
Thank you, Frankie. Indeed, what I did was using two differently sized DCB. One is a 3.020 in the proximal vessel and a more prudent shy balloon 2.5 in the distal. This is the final result, okay? The final result and in two different projections, which I think I was happy with that result, and I dare to leave it like this. I want to show you also another data, which is the physiology, as we said, angio-based. This is micro-QFR. You see that the baseline shows a 74% diameter stenosis and a 0.64 micro-FR baseline, which improves through a 31%, so at the point of being acceptable, this QCA, but a very nice physiology over 0.90. So do you feel comfortable as far with this result? Would you leave that result, or you?
Absolutely. So as I said earlier, Flavio, the angiographic result was fantastic. I do think this case is for experienced operators because the presence of calcium means that many people would have stented that. So I think you have to be experienced with use of DCB to do that. What the chronophysiology tells me, it gives me added confidence on top of the angiographic findings. It gives me added confidence that this is a lesion that you have prepared well. You have left the drug on the wall of the artery, and that I would be confident that this patient will do well after this. So the physiology is added confidence.
Yeah, and I have to be sincere with you all. We did perform the physiology measurement afterwards. The patient was not still on the table when we got this 0.90 micro-FR. We sent the patient home, but the most important and interesting aspect of our PCR webinars on DCB is the long-term result. This gentleman was so kind to come back after 12 months doing perfectly well. I am not saying that you have to do that.
Yes.
We are learning. This patient was included in a trial. So he came for a check. You see that the result is good. There is not such a big vessel enlargement. Probably we can discuss that because of the impressive calcification. But again, what I want to share with you is the physiology. Look at the physiology. There is some recoil. The stenosis now, it's a little bit more apparent than before, but physiology keeps far above 0.80. It's actually 0.86 if I see well, and the patient is doing well.
Yeah. So I think this is a great example. So if you just lack that little bit of confidence, you could repeat the angiogram after the procedure 10 minutes later, do the non-invasive physiology, and if it shows a result like this, you can be confident.
Great. Now we go to our colleagues. We have the questions. The first question was, which was the balloon to artery ratio? And they did pay attention because actually 92% of the colleagues replied 1:1.
Great.
And the others, they replied 0.90. So it's a very good message we have been able to transmit. And the second question was, which type of dissection should we treat or not? We said we should rely with that sense, and 90% said TIMI-3 flow. So
Great.
anything that gives you a good coronary flow, no chest pain, no ECG changes, that means that you can rely, despite the bad aspect, but we will leave this controversial aspect for the final case. Other questions? We are getting many questions. Do we always need, I mean, the question it's a little bit, I will make it clear. Can we use, I have just offered you the example of a balloon-based dedicated IVL, but the question is, can we use rotational devices to prepare calcified lesions?
Well, I mean, just from the example you show us, you can do anything you need to prepare the lesion, and at the end, if you fulfill the criteria, which we have been discussing, should be good enough. Having said that, I mean, your case is a beautiful case, but it's in a study, because we need more data for large vessels and especially for a long LED wrapping up at the apex. Okay. I think you can do that, but we still need more data.
Another recurrent question, and this comes every time we talk about DCB, and I will address this question to Frankie. Can we treat bifurcations with DCB?
Yes, of course. So in my opinion, DCB is a very attractive option for bifurcation. So, for example, bifurcation nowadays, for DCB, we can either do DCB for main branch and side branch, or sometimes we do a hybrid, main branch stent or side branch DCB. Either way, we reduce the chance of using the complex two-stent strategy, which nowadays, we always think that we are going for the provisional one instead of the complex two-stent. So for myself, for bifurcation lesion, I would say DCB is a very good option, provided that we achieve good angiographic result, that is less than 30% residual stenosis and TIMI-3 flow and less than type C dissection.
Okay, so when we go back to using DCB without stents, the point is the assessment of the benignancy or the malignancy of the dissections. So I want to ask Fernando to recap a little bit. He is a very long-lasting, experienced operator, so he has to do with this issue. Please, Fernando, show us your experience.
Thank you, Flavio. So I think it's important when we are discussing the use of drug-coating balloons to remember the limitations of POBA. So first is acute recoil, as Flavio showed a beautiful case. Then the dissection we've been discussing. But then after the initial treatment, you can have also late recoil, which is remodeling, and obviously neointimal proliferation. I think it's important that from the very beginning of plain old balloon angioplasty, the mechanism of the lesion was recognized to be dissection, and also please look at this very old, but I like that very much, you know, in the 80 abstracts suggesting that healing of the coronary artery intimal dissection after PCI was the mechanism of maintain excellent results. So this is not a new idea, and in fact, in the early days of balloon coronary angioplasty, they make some studies suggesting that in fact those patients left with a clear angiographic dissection, providing was not very severe, we've been talking about A and B, the restenosis rate was lower in those patients with the dissection was angiographically visible as compared with cases where no dissection were found. And this has been demonstrated in many studies. So this is a very old study. Look at the time of the publication, but this is at the time where we're using stents just to treat vessels that were having a major dissection, and we need to use the stent as a bailout. So some of these cases had a long distal dissection, and in that study, we performed QCA follow-up and analyzed the results in the Stentec segment. So there is in red, you can see how at 24 hours, but a late follow-up, there is a significant reduction. But the beauty of this study to me is that, there is a positive vessel enlargement at follow-up in the dissected area. And this was not a technical issue of the HQCS system, was this late lumen enlargement that was already seen in the section that were produced with drug-coating balloons.
Thank you very much. There is a very intriguing aspect of the angiographic follow-up of DCB, which relates with dissection. We are focusing our webinar very much on dissections because this is what is, we're talking about the immediate result. And so I will ask Frankie to go back to Transform 1. Transform 1 was a head-to-head comparison in between paclitaxel-based versus sirolimus-based. We have already shown, Fernando, that the trial showed the superiority of paclitaxel, but there is a very interesting observation in this study, which is the response of the later angiographic results to dissections. Frankie, do you want to comment on this?
Yes, so indeed, this is a very, very interesting observation we can see in this study. So in this study on the OCT, actually the investigators, they calculate the so-called the dissection area and this relationship with this area and the late lumen loss. Interestingly, you can see that for the limus type of DCB, somehow the dissection area actually increased with the late lumen loss, which means that if there's more dissection, if you use a limus DCB, there will be increased late loss, which is a bad phenomenon. In contrast, for paclitaxel-based, somehow the dissection volume does not have very a relation with the late lumen loss. Somehow it seems that more dissection, there may be slightly less late lumen loss, which means that maybe the dissection may be good for paclitaxel balloon DCB, but not for the limus-based DCB. And indeed, it's a very intriguing and very interesting observation in this study.
Thank you, Frankie. Indeed, we don't have a clear explanation to that. I will go very, very quickly on our experts on the panel. So, Azfar, your comment on that?
So the greatest evidence that we have, bulk of evidence, is for the paclitaxel-coated balloons. It's a cytotoxic drug. We know it works. The limus-based balloons are relatively new, and we're still collecting lots and lots of data. We don't know about the correct elution profile, the carrier molecule. So I would hold fire on making a judgment too quickly, but data like this is important. But as I said to you, sirolimus-based drugs on balloons are still undergoing evolution.
Okay. Fernando, which is your explanation on that?
Well, when you produce, first of all, we don't have enough information of the meaning of this OCT so beautiful, striking dissection images, and we are learning from that. And I think the problem with using OCT is that perhaps many people will see the dissection better and will proceed with the stenting, which I think is a mistake. I think the dissection set free the vessel, and this allows the possibility of late lumen enlargement, which is a major mechanism of drug-coating balloons, and appears to be more profound in patients treated with paclitaxel lumen balloon. The other issue that we've been discussing is that there are some animal studies suggesting that the distribution of the drug along the vessel wall is different, and there is a more important concentration of paclitaxel near the adventitia, and perhaps this can promote the result of late lumen enlargement when there is a medial dissection, so that the adventitia is reached by the paclitaxel, and then you got this positive effect.
That's a good point. We always have dissections. After dissections, paclitaxels will go beyond the media. Sirolimus will not, and probably that will favor more vessel enlargement. But we don't know. I mean, it's a curious observation. It's very recent, and we wanted to share this image with you. But since we are moving to more complex intravascular imaging, I want to show you a case which is an example of what you get when you go inside the vessel and with very high-resolution techniques interrogate the results of your balloon angioplasty. This case was done more than 10 years ago, at the time when BVS Absorb was very popular in my lab. I have always been a believer on stent-less interventions. This is why we are also passionate on DCB. It's a very young patient with very diffuse disease, as you can see, presented with an acute coronary syndrome, chest pain, STL segment changes in the anterior lid, and troponin rise. And it's clear that it's a very diffuse disease. This very diffuse disease poses the question, and this goes to you, is the last question of the day: how many millimeters of drug-eluting stent would you need for this patient? Option 1 will be 20, option 2 will be 40, option 3 will be 60, option 4 will be more than 60. Well, while you reflect on that answer, I will show you what I did. As I said, more than 10 years ago. It's a vessel preparation with a 3O semi-compliant balloon along the vessel from the proximal to the distal part. And as I said, we had enrolled this patient in one of the Absorb studies, so he got a 3.528 Absorb in the proximal part only. But we post-dilated all the vessel distally with a good all-impact Falcon balloon, which was one of the precursors of DCB technology, always paclitaxel-based technology, for a long tract from the mid to the distal LAD. So what you see here is the angiographic aspect. Of course, there is no doubt that there are long and also, I would say, spiral dissections with a good flow. Asfar, do you like this angiographic result? Would you dare to leave it as it is, or you would go to full metal or full plastic at that time jacket treatment?
Yeah. No, once again, I will say again, angiographic restenosis less than 30%, which is apparent to me. TIMI-3 flow, we have to be consistent. I would leave this.
So you are faithful to what we said in the beginning, but what we said in the beginning is the experience we are developing now. This was done 10 years ago.
Yeah, so 10 years ago, if you hadn't had that experience, maybe you would consider putting a big stent in the proximal LAD, is restore flow, and hope that flow remodels, but I certainly wouldn't have full metal jacketed even 10 years ago.
Okay, Fernando, do you agree with that? We are all operators, so it was done 10 years ago, but at that time we had already 20 years of experience in intervention.
So, I mean, the beauty now is that we can have hybrid strategies, and we can have, perhaps if you prefer, blended strategies where we can fix the proximal part, the more severe disease, with a best generation stent, and you can treat the rest of the vessel with drug-coating balloons, so that the full metal jacket strategy would be avoided.
Okay, so we all agree that angiographically it would be comfortable. We are expert operators. I remember doing that case. My colleagues were saying, are you sure you want to leave this young patient with this LAD? And I did OCT. Look at the OCT. So OCT will inject contrast at high pressure, so will worsen any kind of dissection, and then tells you the truth. I mean, what you imagine it's a benign dissection, probably a little bit spiral, looks like this. And you are all watching this image. This is the distal LAD, but of course, we can see also the mid and proximal. And I will leave this image running until we will see the bioabsorbable scaffold. Now that you see the dissection as far, would you still remain on your idea of leaving it alone, or these images frightens?
Yeah, no. So the imaging, you can have too much information, and I think the OCT is giving you too much information. The bottom line, as I say again, TIMI-3 flow, non-restrictive dissection angiography. The OCT image is of interest only, not for action.
Great point. You see now the BVS, the big struts, transparent strands in the proximal part, well-opposed, nice vessel, but this is not the point. Fernando, after this OCT.
I mean, just let me go to the stent strategy. I mean, there is data from Francisco Prati and other people saying that this kind of dissection by OCT, edge dissection, should be treated. And now we are in the drug-coating balloon era where this similar dissection, significant arch, more than 120 degrees, reaching to the media. I mean, you nearly got that into the adventitia, and still, we know that with drug-coating balloons, most of these dissections fare very, very well.
Look at 18-month follow-up. This 18-month follow-up was based on our initial experience with Absorb. It was supposed to be absorbed, but it was not. But what is useful of this angiographic follow-up is to check the absolute lack of restenosis and the complete healing of the dissections. So we repeated the OCT, and again, you can see with a very, let's say, accurate imaging that there are absolutely no dissections remaining after 18 months. Of course, 18 months, it's a very long time. You could have had infarctions and occlusion. Dissections heal much faster than in 18 months. But we were very happy about this result. We were not happy about still seeing the struts of the Absorb. So as the patient was enrolled in an Absorb study, he came back 4 years later. We have more than 10 years follow-up of these patients doing very well. And you see that even 4 years later, there is no restenosis, there is perfect flow in the mid and distal LAD. And we repeated the OCT of this distal LAD and proximal, and I will leave this image because it's so beautiful to see the complete restorage of the media and the intima of this vessel, and we want to hear your comments. But we have to go back to our colleagues. There are more questions, very practical. One is, I will address this to you, Fernando. Do we always need to use a non-compliant balloon before using DCB, or we can rely on semi-compliant balloons?
I think we can rely on semi-compliant balloon if we achieve our goals that we've been discussing.
Okay. As far, similar question, is it safe to use high-pressure cutting balloons before using DCB? It's a naive question, but
yes, absolutely. So stepwise approach, as Fernando has said, use a stepwise approach, go to more and more aggressive balloons until you get the result you want. If there is flow limitation after that, you have the wire, put a stent in.
Okay. So, any comments on this previous case when you have these, let's say, nasty images on OCT? How often do you use OCT in your practice after you have done DCB?
After DCB, never. So OCT is pre-procedure and then post-stent.
Okay. Frankie, you are used to treat long lesions and small vessels, which are very common in Southeast Asia. Does the use of OCT add anything to your practice, or you rely on angiography?
So usually for small diffuse disease, for DCB, I usually just use angiography. And as common to all of us, when they do OCT, we see more and we get scared off by doing the DCB. So for myself, for DCB, usually it's pre-lesion, also post-stenting, or pre-lesion preparation before DCB, right? But for small tortuous distal lesion, usually I would just go with angiography.
Great, very good point. We are 1 minute from the end, but Fernando wants to say something very important.
Well, I think it's important. We don't have the data and we don't use it. But the beauty of this is that the answer should be there. With OCT, seeing the vessels, seeing the dissection, the answer is there. So we need the data.
Thank you. Well, we are approaching the end. I want just to read one final comment that I like very much. A colleague said, excellent cases, thank you for that. And we think that this is the best reward we can get from these 60 minutes. And we go to the end. I mean, the end is the conclusion. We are keeping the same conclusions we provide you in our previous DCB because it's a part of the same course that we want to share with you. Diffuse CAD remains a challenge for PCI and for CABG. And DCB may allow a normal arterial wall without metallic struts, with preserved vasoreactivity, this has been shown, with free bifurcations, this is clear, with less stimulus for neoatherosclerosis, which means not known stimulus, less stimulus than having a permanent foreign body. And of course, we cannot foretell the future. We have room for yet unknown forms of therapy. But before leaving you, I want to remind you that these points need to be defined, and the cost-benefit analysis of this therapy is becoming an issue because the cost is different in different geographies. With that being said, I want to thank you for your attention, but above all for your participation, which makes these PCR webinars more attractive and interesting. We do hope that you have enjoyed. We know that you have been listening, you have been watching, you have been participating, but above all, we hope you have learned and transferred this learning in the benefits of your patients. Thank you. And thank you, friends, for being with me today in Paris.
Thank you.
Thank you.